mừng tất cả các bạn đến phiên số 2. Phiên này chúng ta sẽ có trình bày một gọi là like in a box. Chúng ta biết đây là một trong những các cái định dạng của chúng ta báo cáo khi chúng ta đã làm quay một cái ca lâm sàng, nhưng mà chúng ta sẽ có những cái trình tự giống như là chúng ta làm một live case và chúng ta sẽ có những thảo luận. Thì đồng chủ tọa với tôi hôm nay có giáo sư Võ Thành Nhân, có phó giáo sư Narrative đến từ Thái Lan, và các thành viên trong ban bình luận viên và tham vấn của tiến sĩ Ngô Minh Hùng, tiến sĩ Vũ Hoàng Vũ, bác sĩ Phan Tuấn Đạt, tiến sĩ Phan Tuấn Đạt và tiến sĩ Hoàng Văn. So we go to the like in the box from Singapore, please. Bên bộ phận kỹ thuật, xin mời bộ phận kỹ thuật đã có xin cho kết nối ạ. Hello.
Hi,
Hello, can you hear us?
Yeah, I can hear.
Okay, very good. So we here in Nha Trang, Vietnam, on occasion of the Ho Chi Minh City Society of Interventional Oncology. So we are very happy to have your like a box from Singapore. So I would like to introduce our chair here. We have Professor Võ Thành Nhân. I myself, Professor Phạm Mạnh Hùng from Hanoi, Professor Võ Thành Nhân from Ho Chi Minh City, and Professor Narrative from Thailand. And we also have our team of the panelists here. So I would like to ask you for the slide for the introduction and present the case, please. Thank you.
Okay, a very good morning to the panelists and everyone there in Vietnam. So I'm Dr. Vignesan, interventional cardiologist from Sultanate Aminah Johor Bahru from Malaysia. So first of all, I'd like to thank the organizing committee for giving me this opportunity to present a live case in the box. So I'm very sorry that I cannot be there physically with you all. So without further ado, I will proceed to my case presentation. So my patient is a 63 years old gentleman with a background history of type 2 diabetes, hypertension and dyslipidemia. He initially presented to the private hospital with a non-STEMI in October 2024. An angiogram done showed significant stenosis in LAD and RCA. So in the private hospital, PCI was done to LAD and subsequently was referred to my hospital for a stage PCI to RCA. But before the date for his PTI, he had an admission again in April for non-STEMI, and we gave him a PCI date on the 27th of May. So this is his baseline blood investigation. Everything seems to be normal and nothing significantly abnormal. His ECG baseline is a right bundle branch block. Echo good LV function with EF 60-65, normal valves, and so this is the initial coronary angiogram that I did on 27th of May. So we relooked the LAD stent, but he had a new stenosis distal to the LAD stent, about 80 to 90%, circumflex relatively normal, and the RCA, there's a severe stenosis from the proximal to mid of RCA and significantly calcified. So during the 27th of May, we did a PCI to the LAD first with a DCE 3520 and subsequently brought him back again for the stage PCI to the RCA. So for the RCA, our strategy was radial approach. We used a 6 French guiding catheter JR4. We put a TPM in the right femoral vein, iris guided, and based on the iris finding, KIV for atherectomy, which is rotational atherectomy plus minus IVL. So I would like to ask the panelists what would be your approach for this for the RCA?
Thank you so much. So we are so sorry for wrong introduction from you, Dr. Vignesan from Malaysia. Thank you so much for attending us. So may I ask our panelists and our audience have any questions? So Dr. Natalie. Yeah.
So I agree with your plan, except I'm from Thailand, and in Thailand IVL is not reimbursable, but rotational atherectomy is fully reimbursable. So in my case, I agree that this is heavily caste violation. I would do the same thing, radio approach, um, JR. I think JR 6 strand JR4 is a good choice, and then I'll do IVAS, and then for me I'll use just rotational atherectomy, maybe with a bigger burr. I might upsize to Y175 is needed because IVL is like an issue in Thailand.
In Vietnam, IVL is not available. So I think that in my center, I will probably do the rotational atherectomy, and then if needed, I will add a cutting balloon to crack the calcific stenosis.
Okay,
Không biết
thank
các
you for your opinion.
các panelist có ý kiến gì thêm không ạ? Okay, one of our panelists have some comments.
Yes, thank you for your case. I'm Dr. Wu from GMC. So in this case, we have the RCA heavy calcification, and also we have a tortuous RCA. So my approach is that first one, I would like to choose the 7 French guiding catheter, and I would choose the AL1 with the side holes. And I think this case we should check the IVERS OCT first to see what happened with the RCA. If the device cannot cross a lesion, I would choose the rotablation atherectomy for this patient. At the beginning, we start with the 1.75, 1.25 first, rotabur, and after that, we can upside the burst to get the bigger lumen and even preparation well. And after that, maybe scoring a cutting balloon or anything. In Vietnam, we don't have the IVL, but I heard that one IVL available maybe 3 days ago. So I think if it depends on the final result of the IVERS finding, after rotablation and IVERS finding, we would choose the IVL or not, if IVL available in our CAT labs. Yeah, thank you.
Okay, thank you. I also agree, and my strategy plan also to do with the rotablation. But I have one question for you, Dr. Vinesh, and for the previous lesion in LD with 3.5 mm and in diameter. So why do you use the DCB instead of the DES?
Because we are quite comfortable with DCB, and usually we will prepare the lesion using an NC or scoring balloon, and if there is not much of recoil and residual stenosis is less than 30%, we prefer to use DCB than rather putting in another metal, because for the RCA I anticipated most probably he's going to get a stent, and he's a 63 years old man, so I think DCB for our center, if we can DCB, we will try to DCB.
Thank you,
most
sir.
our DCB usage in our center is actually quite very high.
Okay, how many percent you estimate?
My DCB usage, I can say about 60 to 70%.
Wonderful. Thank you so much. So go ahead to do with the plan. Yeah.
Okay. So I will proceed with my presentation. So this is the initial shot that we took, and with the TPM in situ. So initially I was anticipating difficult wiring, but actually the wiring went quite smooth. This is a Sion Blue wire, and the wiring was quite easy. And following which, since the lesion was very tight, we decided to try to push down a 2O balloon, because with that kind of tight lesion, I anticipate the iris catheter has difficulty going down. But the 2O balloon only up till the mid RCA, so only it can go up till the mid RCA, can't go further down. So I changed to a 1O smaller balloon to pre-dilate, but it's also stuck at this point. Okay, but nevertheless, I still pre-dilated with the 1O balloon first. Okay, then after the 1O, I re-attempted again with the 2O balloon. Okay, but as you can see, there's a very bad dog boning here with the 2O balloon, and the balloon did not expand. So then I tried, after putting the 102 balloon, I tried to put in the iris catheter. But again, the iris catheter is only up till the mid RCA, and I could not push down the catheter further. And so the pullback from this point, also we can see there's severely calcified 360 degrees calcium. But this is not the MLA. The MLA is further down. So this is already, we can see 360 calcified from the mid RCA, and the proximal RCA has some areas of calcification, fibrocalcific plaque at 12 to 1 o'clock, and subsequently the proximal RCA is quite healthy. So probably we could land the stent in the proximal RCA and don't need to go all the way to the ostium RCA. So the proximal RCA vessel diameter is about 4.5, and this part, which is just above the tightest lesion, the MLA is already 3.69 with 360 degrees of calcium. So in view of a balloon uncrossable lesion, we decided to proceed with the rotablation. Okay, so we used the 1.25 per rota, and we started off with 180 RPM. If you can see in this video, the lower right video, you can see that the rota also had initial difficulty crossing the midpoint, and then there is a sudden jump of the burr. Okay, so after 3 runs, after 3 in and out, then only the burr actually passed down. Okay, so we did total of 3 runs at 180, 1 run at 200k RPM, and the final polishing run at 160. We anticipated the slow flow, which it did happen. So following rota, there is slow flow to the RCA and the ST elevation of the inferior lid, but patient remained hemodynamically still stable, and he had a transient bradycardia. That's the reason we put in the TPM. After this, we gave a bit of adenosine, and the flow actually improved. So next, we put in a scoring balloon. We put in a scoring balloon, 2.5 scoring balloon first, but again, it only could go up till this level, and we can see when we expand the balloon, there's actually still dog boning of the balloon at the tightest point. The proximal part seems to be opened up fairly well with the 2.5 scoring balloon, and after this, we proceeded with another IVUS, okay, from the distal RCA. The distal RCA, we can see there is a fibrolipid plaque, okay, and this is the tightest point. Okay, this is the most tightest MRCA with a circumferential calcium. Okay, and the proximal, like as we saw earlier, is relatively healthy, and okay, and there is some calcium here also at the proximal region. Okay, so this is the distal, right? At this point, is there any comments from the panelists?
So I think not normally I'm very aggressive with rotational arthrectomy. I would aim at like 0.5 to 0.6 burr to artery ratio, but I think this case I am hesitant to upsize the burr since we got the slow flow already. So I think it would be a good case to perform other method of plaque modification like cutting balloon or scoring balloon or even IVL.
So in our strategy, when you using the burr, do you prefer the I think a little bit aggressive, like Dr. Narrative, to use the size of the bird with the diameter of the vessel. And the second thing I would like to ask you, so would you prefer the high speed or low speed bird?
So generally, I would prefer to start off with 1.5 per, but with the initial balloon, even with the 1.0 balloon, I had difficulty going down. I was a bit worried that the calcium burden was too much, and if I use a bigger burr and the calcium shower down to the vessel and causing slow flow or even bradycardia, so it's a bit worrying. So basically, the reason why I chose 1.25 is just to create, just to clear the pathway sufficient enough for me to pass down any other balloon or IVL for that matter.
Thank you. So any comments?
So how about the speed of the rotational
Oh, sorry,
atherectomy? Yes.
the speed generally I will start off at 180, and so during the rotablation at 180, we felt that it wasn't it didn't clear much, so that's why there was one run we went up to 200, but 200 rare occasions only I will go up to 200, but generally 180k rpm, and then polishing run about 160 to 170.
I have one more question.
Yes.
Have you ever used the guide wire, pacing guide wire, instead of using a normal temporary lead for pacing during rotation?
Sorry, you mean use the guide wire as a pacing?
Yes. Just like
Oh,
we
no,
use the guide wire for pacing during type V procedure.
Oh, no, 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 no. I've never done that. Usually, for RCA, we will put in a temporary wire.
Okay, thank you. Chúng tôi vừa mới hỏi ông ta là có bao giờ sử dụng cái gai quai làm cái điện cực để mà đặt máy tạo nhịp tạm thời hay không? Tại vì trong TAVI á, thì mình có thể dùng cái gai quai để mà làm điện cực tạm thời trong quá trình làm TAVI, và trong y văn á, thì khi làm rotator ở cái động mạch vành phải á, thì người ta dùng luôn cái dây dẫn đó làm cái điện cực để mà đặt máy tạo nhịp tạm thời, chứ không cần đặt cái electrode, không cần đặt cái điện cực tạm thời.
Yes, I think at this point we have the slow flow, right? And we just done the rotation 1.25. So at this point, I think the bigger burr is not suitable in this situation because we have the slow flow. So, but by the IVERS finding, I found that we have some crackle already in the RCA, and the tightest lesion calcification is short. It's not too long, and we have the minimal lumen area is about 1.65, right? So if we, I think in this situation, I think I would choose the NC balloon, because the scoring balloon is not the NC. It's just semi-compliant. Is it the semi-compliant and scoring balloon, or just semi-compliant? In my experience, I would do the NC balloon with high pressure. I think the calcification could be better in this situation. And other option is IVL, right? IVL is a second option, but it's a lot of money. It's a lot of money. So in my opinion, I would do the NC balloon with a high pressure, about 3 or 3.5 NC balloon to do in this case for the next step.
So you mean you use a super high pressure balloon like OPN balloon, so up to more than 30 atmosphere, right?
Okay, so this is the IVERS after the rotablation and plus the scoring balloon. So yes, like you mentioned, there was some cracks, but at the tightest point, the crack seems to be a bit more quite minimal, and we, after using the scoring balloon, it did not expand that well. So then, based on this IVERS, and we decided to proceed with IVL. So we used the Sonic Tracker IVL by Biosensor. We chose a 3.0 by 12 mm IVL. Okay, so this IVL length is 12, and it has total of 80 pulses. Okay, so the IVL actually went down quite smoothly to the tightest part. Okay, as you can see, so the treatment inflation pressure is 6 atm. So after we inflate to 6 atm, okay, we will press the delivery, and it will deliver 10 pulse each cycles, so total of 8 cycles. So if you can see this lower angio, okay, the initial dilatation of 6 atm, you can see the balloon is a bit wasted. After we deliver the 10 pulses, the balloon seems to be a bit bigger, and it has expanded. Okay, I'm not sure whether y'all can appreciate that. Okay, let's see whether the video will play again. Okay, so following that part, we did all the way from the lower mid to the proximal RCA, and we completed delivering all the 80 pulses. Okay, so I will show back again the beginning. Okay, if you look at the balloon, when it was initially dilated before delivering the pulse, there was wasting at the distal part of the balloon. Okay. After we deliver, you can see that the balloon expands slowly. Okay, it'll be much more clearer when we took a cine after the balloon has expanded. Okay, so the balloon seems to be a bit bigger. So next, this is the post-IVL IVERS. Compared to the initial IVERS, we can see more cracks and more reverberation from the calcium cracking, and as you can see, the minimal lumen area has actually grown a bit more bigger. Okay, so the distal reference is about 3.5 mm, and the proximal reference landing zone is about 4.5 mm for this vessel. Okay, after seeing this IVERS after the IVL, we were quite happy, and with the cracks and everything, but we still pre-dilated further with the 4.0 NC at 12 to 14 atm. Okay, all the way from the lower mid RCA up till the proximal. As you can see in this short cine, the tightest part where the initial MLA was, the balloon actually expanded quite well. Okay, this is the angiogram after IVL and after the 4.0 NC. So since the balloon expanded well, what is your opinion on this? Would you prepare more, or would you start doing stenting after this?
So in my practice, I would do DCB and I'm done. Because I think for stenting, you need more aggressive predilatation. I think the distal RCA part, there is still some residue stenosis. I mean, for stenting, I prefer to put like 4 or stent, but it would need more aggressive predilatation. But in this patient, I am happy with the lesion preparation. You did a wonderful job. I would be done with DCB.
In my opinion, because so far we don't have enough data support for the laser version using the DCB, so this something like a 4.0 version. So I still concerned about the DCB in the long term, so I would do the DS then. In this case, I think it's the lesion preparation is very well, so I think that we go ahead to do with the stenting.
I think if you're going to do DCB for the whole of the RCA, I think we need to prepare a bit more. We need to do more preparation, maybe with another scoring or even a cutting balloon. Okay, so for us, what we did was for the distal part, we were quite happy because there's not much recoil and the residual stenosis is not too bad. We applied DCB at the lower part, 35 30 DCB, and proximally we stented with the Biofreedom Ultra Stent 35 36. So the stent subsequently we post dilated with a 45 NC, 12 to 18 ATM, higher pressures at the proximal. Okay, and this is the IVUS after we stented. So at the tightest area, the MSA we got was 8.6, and the proximal RCA we got about 15 MSA, and the distal stent edge we got about 9.8 of MSA. So this is the final angiogram.
Okay, I have a question for you at this point. So why
Yes.
you choose 3.5 stent and you post the leg with 4.5 balloon?
Oh, because at that point we wanted a 30 something stand for 4.0, but unfortunately at that point the 4.0 stands we have were like the longest we had was like 20 something. We didn't have the length that we wanted. So instead of putting two stands, so we decided to put in a 3.5 stand, and the Biofreedom stand actually a 3.5 stand can be well expanded up till 5 point until 5.0 I think.
I think for Biofreedom Ultra, 3.5
Yeah.
and 4.0 has the same platform anyway. It's just the
Yeah.
difference is the balloon.
One question about the preparation of the heavy classification. So this patient will have the RCA about 4 or 4.5 mm. So in daily practice, should we use the bigger balloon to prepare in this situation 4.0 or 4.5, or just keep it 3.5 or something? In your experience, Dr. Big Nexan.
Oh, if the usually I will try to go one to the vessel, but since this is heavily calcified, I was a bit cautious to go one to the vessel because I don't want to get any dissection and all that. So that's the reason we even our IVL also we use the 3.0 to open up the tightest part, and we decided to use a 3.5 stand because of the reason I gave, but we managed to post dilate it up till 4.5.
May I have questions about the IVL system?
Yes.
Yeah, this you use this Sarkai system. Is any different or is any special in compared to the conventional shockwave system? Yeah.
The device as such, the concept is the same, but the console and the pulse delivery system, it is slightly different. Actually, I have after this I'll be talking about the IVL system, and I can show you. But the difference is there is a two. The console has two ports for you to connect. One is for the pulse delivery system, and the other one is to the balloon. So compared to the shockwave, there's only one connection to the pulse delivery system.
Is it cheaper compared to shockwave? At least in
Yes.
Malaysia. Yes, I think that's the
Yes.
key.
Yes, it's about Malaysian ringgit, about 4,000 ringgit cheaper in Malaysian money, Malaysian ringgit, yeah. So, but I'm not sure what's the conversion, but it's definitely cheaper than, and compared to shockwave, the deliverability of the sonic cracker is better because the tip is a bit more better to deliver compared to the shockwave. It's a bit more bulkier. Yeah.
So, Dr. Vic, since IVL is not common in Vietnam right now, and I just want to ask you about the rotational atherectomy.
Yes.
So this vessel is quite big. I think the inverse is 3.0 to 4.0. So I think that
Yeah.
rotational atherectomy will not work well on that case because the vessel is quite big. So what do you think about the orbital atherectomy?
Yes,
It can be
orbital
work properly in that case, and I think that this is an alternative choice for that case.
Yeah, definitely. Orbital atherectomy is also an option, but I think, frankly, personally, I'm a bit more comfortable and quite used to rotational atherectomy. So that's the reason I chose rotational atherectomy. Honestly, compare for myself, I done more rotational atherectomy compared to orbital. So that's the reason I chose rotational atherectomy.
Yeah. The second question that based on diverse finding, I see that some hematoma on the on the proximal RCA. Are you confident
Yeah.
that to leave it alone? That's only the stand to the mid part, and you follow the patient for the hematoma of the osteomes.
Yeah, I mean, we realized that, but at that point, we think it was okay because it's quite small. And actually, following the procedure, we waited about 15 to 20 minutes, and we, repeated the angiogram. The hematoma seems to be quite stable, and patient remain asymptomatic. But but we are keeping a close watch with the patient, and we will bring him back again for a relook.
Uh, so about the DCB, I know that you are expert on the DCB because daily practice over 50% of PCI case you use the DCB. So
Yeah.
so how about this patient? We found that maybe in the lab and on the right hand side angiography we see some maybe spiral dissection of the distal RCA at the position of the DCB. And by the IVERS
Yeah.
finding, we see some big dissection over there. So can you share with us some experience about the DCB when we stop the procedure with the DCB and when you put another stent to buy out the DCB before that with the IVERS or just angiography. So can you share with us your experience?
Yeah, so for DCB, yes, some interventional cardiologists, they are very afraid of dissection. So the concept is, if you are planning for DCB, some amount of dissection is acceptable, and in fact, it is DCB works better when you have dissection. So when do you bail out with the stent is when the dissection is causing flow limiting dissection with or patient is symptomatic or there is some ECG changes. So then definitely we need to bail out. So for this patient, we realized there was a dissection, but after a couple of minutes, we waited and there was no flow limiting. Patient is asymptomatic. Hemodynamically, he's stable. No ECG changes. We were comfortable to leave it alone because because we have applied DCB at that area, so eventually it will heal and it will positively remodel. So when you do DCB, you must be prepared and to have a not so perfect angiographic view. In DCB, we must learn to accept that angiographic, it won't be like a stent. Okay, there will be some stenosis, there will be dissection, but eventually it will heal. So the key point is when you have a flow limiting dissection, that is when you have to bail out.
Okay, thank you so much, Dr. Venus. So I think you still have one more short presentation, right?
Yeah.
Okay, so please go ahead. Yeah.
Okay, so firstly, I talk about this Biofreedom Ultra stent. Okay, so it has a Biolimus A9. It's a similar mechanism of action of any other limus drug and higher lipophilicity than all other limus drug due to its modification of their chemical chain. Okay, and has greater local bioavailability, and because of the properties of the BA9, it allows for potent neointimal suppression and also has a prolonged action until 100 days. Okay, so the thing about biofreedom stent is the large cell opening for easy side branch access, and also the expansion. As we know, the 3.5 stent can actually expand up till 5 mm. Okay, and it can 5.95, in fact 3.5 can go up to 5.95 mm, and the 225 to 30 can actually expand to 4.76 without any damaging in the struts. Okay, the evidence for the stent is these main three trials: leaders free, leaders free 2, and leaders free 1. So leaders free 1 is it's comparing to bare metal stent, which is we know that DES is better than bare metal stent. Leaders free 2 is basically confirming the finding of leaders free 1, and is superior than bare metal stent in the from the primary safety endpoint and the efficacy endpoint. Sorry. Leaders free 3 is Biofreedom Ultra, okay, and it's non-inferior to the other stent and safety superior to the BMS. Okay, so Biofreedom Ultra is the a stent which has a 1 month DAPT recommendation, especially those with high bleeding risk. Okay. So for elderly patient with high bleeding risk or patient with chronic kidney disease, we can confidently give 1 month DAPT if you are using this Biofreedom Ultra stent. Okay, next I'm talking about this biosensor IVUS True Vision. Okay, so as we know, intracoronary imaging is very important in pre-intervention to assess your morphology, length, diameter, and post-intervention is to assess dissection, apposition, and expansion. So IVUS is a class 1A recommendation for complex lesion, left main, true bifurcation, and long lesion. Okay, so the True Vision IVUS catheter is the same as any conventional IVUS. It comes with a catheter, pullback console, and also a console for interpretation. Okay, the difference is it has a faster pullback, can go up 10 mm per second. Okay, the slowest is 0.51, and it has 3 mm per second, 5 mm per second, and 10 mm per second for the fastest. And the catheter is 150 mm length. So if you have a large and a long vessel, you can pull back in one single pullback, and as the compared to the competitor, sometimes for long lesion you need to uh, reset the thing and continue pulling back from where we stopped the earlier. Okay, and because of the 10 mm per second, your duration for the long lesion pullback is also faster. But a lot of people will ask, if you pull back so fast, would your image quality be the same? Yes, during the pullback is fast, but the image quality still remains same. And this IVERS is 60 megahertz. Okay. So it also comes with the AI interpretation to give you the minimal lumen area, the plug burden, and also auto segmentation for calculation of the MLA and MSA. Okay, then it's a short brief introduction about Sonic Cracker, the IVL from Biosensor. Okay, like I said, this is the console where you deliver the pulse. Okay, so there is two connection. One is to the balloon, one is to this is the pulse delivery. There is the leg type and also the hand type. So where the hand type, we will just press the button and the pulse will be delivered. Total of 80 pulses, intervals of 10. So okay, this is the one. Okay, so this is a patented electrode design capable of achieving higher acoustic pressure intensity and more uniform shockwave distribution. So Sonic Cracker comes in two lengths, 12 mm and also 15 mm. As compared to the competitor, only they have is 12 mm. In the central region between the two electrode, it distributes sufficient acoustic energy, more than 3 megapixel, enabling the design of the 15 mm length balloon, and also enhances the efficiency. So the balloon has a dual layer construction and is better suited to conforming to the vessel wall, and balloon is softer, okay, and also has a high RBP, allowing higher expansion pressures. Okay, this is the study they did for Sonic Cracker. This is the lead frame study design and results. Overall procedure success rate is 96.7 and residual stenosis with a stent, no major cardiac events. Okay. So with that, I think I thank you. I would like to thank HSIC again and my team on that day who we managed to do this case successfully. Once again, thank you for giving me this opportunity. And is there? Okay, thank you very much.
Thank you so much, Dr. Vignesh, and congratulations for the case and as well for sharing our very many
Okay, thank you.
very informative. So we still have some few minutes, so I may ask our panelists here and our audience have any question for you about the new system they may have. Thank you.
Sure, sure.
Và các bạn có những câu hỏi nào về những cái hệ thống và những ca lâm sàng mà bác sĩ Vignesh vừa chia sẻ, và xin mời chúng ta cứ hỏi. Xin mời.
Yeah, morning. Congratulations on your interesting case. Comment your case. I have some comments. The first one is the guide carrier. So normally it's a heavy calcification there. So I use Amplas 0.7.5 or femoral approach view IL1. The first one is regarding the intravascular imaging. So there are two options there. OCT or IVERS. Yeah, for heavy calcification, there's I think the OCT a little bit better. I'm not sure your opinion. That second, so is a pinal angiogram. There's and IVERS shows it's very good result, but stands still a little bit under expansion in mid segment. So normally I have the same opinion. My colleagues mentioned above is we need to prepare the lesion is more. So before we make sure that calcium is a cracker, and then we put stent is better. And regarding the distal RCA, that there's a dissection. Yeah, so you use DCB. yeah, that's okay because I think this is a very small decision, Taiwan decision. Yeah, we don't worry about that's the progress. Yeah. So it's a for IVL is um, the two cases was done in my hospital is a few days ago. Um, um, so I think the sonic tracker is a balloon. So that's a double layer. Yeah, double layer. It's a different from other company. For example, software or other company. So because I have experience from my colleagues in your country, Rosli and Dr. Rosli and other. So
Yes.
yes, if the shockwave balloons the rupture, so very big problem. They go 3,000 US dollar down the down to the drain, right? So it is
Yeah, correct.
a sonic reactor is a dual, yeah, dual layer.
Dual
So
layer.
I think that's a less rupture balloon. So that's my comment. Yeah. Once again, thank you very much for your presentation and your case. Very very interesting. Yeah.
Okay, thank you so much. I would like to ask, is there will there be IVL soon in Vietnam?
Yeah, we hope so. We hope so. Yeah. I think
Yeah,
already there are for the clinical use in one center in Vietnam a few days ago, but I think it will come very soon in and have approval from the Ministry of Health. Yeah.
because I think it's good to have IVL because sometimes rota it's very technical and you will need a lot of experience and exposure doing rota or OAS, right? So IVL is quite straightforward like any other balloon and it's quite easy to use and it saves a lot of time.
Yes, I heard that in Malaysia, IVL is quite popular, and
Yeah.
in Thailand, it is not commercially available yet. I know that biosensor approach my center. I think we're gonna do more cases, but initially I thought I wouldn't need it to be honest because we are a big broader center.
Mm.
Um, we have we run a robust course, in our hospital, and usually I'm aggressive with rotational arthrectomy, but I think your case is a good example that in sometimes you cannot be more aggressive with
Yeah.
rotational arthrectomy in RCA with no reflow. I think this is a good demonstration that in some situation IVL is helpful, although you
Yep.
prep the lesion with rotational arthrectomy already.
Yeah.
Okay, so also the time is also run out. So again, thank you so much, Dr. Vishenran, and for very interesting cases sharing, and also for some information about the new technique. So I wish you have some time to come here in person to attend our further meeting in Vietnam or in somewhere. So again, thank you so much, our chairman, and thank you our
Yeah.
panelists, and thanks to all our audience. So I would like to close our session today. Thank you. Thank you.
Okay. Thank you so much. Thank you so much.